Bismillahirrahmanirrahim. So now we will continue from the metacarpal fracture, metacarpal neck fracture. So also called as boxer's fracture, common fracture caused by the direct blow. Just give me a second. Yes. So the metacarpal neck fracture is also called as a boxer's fracture, common fracture caused by the direct blow with a closed fist, for example, from punching a wall or individual. Most commonly seen in fourth and fifth metacarpals. That is in unprofessional, the people who are unprofessional, or the person who just got himself into fight for no reason. So these are the people who fracture the fourth and fifth metacarpals. In the professional boxers, normally the second and third ones are fractured. So we saw that in the 100 points. You can get to that in the 100 point videos. So moving forward to the carpal tunnel syndrome. First we have to see what carpal tunnel actually is. So carpal tunnel is basically a tunnel from which the flexor tendons and most predominantly the median nerve is passing from the forearm into the hand. I'm sorry, from the forearm into the hand. So here you can see that the median nerve is inside this tunnel. This tunnel is basically formed by these carpal bones, the proximal carpal bones, and the flexor retinaculum forms the roof of it. So the flexor retinaculum is basically a tendinous sheath, you may say that. It is connecting the pisiform bone to the tubercle of the hamate, and it is not just pisiform. Okay, so pisiform and triquetrum, but pisiform to the tubercle of scaphoid, and it is connecting that, and that forms a tunnel at the base of your hand over here, like somewhere over here. So we have flexor retinaculum, then tubercle of scaphoid, and this is the scaphoid bone, lunate and triquetrum and carpal tunnel. Entrapment of the median nerve in the carpal tunnel between the transverse carpal ligament and the carpal bones, that is called as nerve compression. Entrapment of the median nerve in the carpal tunnel between the transverse carpal ligament and the carpal bone, that is called as nerve compression. Presentation: paresthesias, pain, and numbness in the distribution of median nerve, that is first three digits and radial half the fourth. So first three digits and the radial half the fourth. So if we see it over here, we have seen that already. Just to reinforce the concept, this one, as you can see, first three digits 1, 2, 3, and the radial half or the lateral half of the fourth digit is also supplied by this nerve, that is median nerve. So coming back to the point, so paresthesia is basically the pain and pin pricking sensation that you feel in your hands, that is normally felt when you the nerve supply, that's not nerve supply, we call that in Urdu that the हाथ या पाँव हमारा सो गया है, ठीक है, we call it like that, and that is the paresthesia. So Google it, I guess you will find better explanation of the paresthesia over there. Paresthesia is pain, numbness, and distribution of the median nerve, first three digits and the radial half of the fourth. Weakness of thumb, abduction, and opposition. Thenar eminence atrophies, but sensation spared because the palmar cutaneous branch enters hand external to the carpal tunnel. That is very important, that the sensations are intact. Here you can see that the palmar cutaneous branch is entering over the carpal tunnel. It is not passing this branch. The palmar branch of the median nerve, this is a sensory branch, or not sensory, cutaneous sensory branch. So this nerve is passing or bypassing the flexor retinaculum and moving over that. It is not entering the carpal tunnel. So this one is spared in the case of carpal tunnel syndrome. Suggested by positive tinal sign. Tinal sign is percussion of the wrist causes tingling. So if we cause the percussion of the wrist, so that will cause tingling, and fennel maneuver, 90% flexion of the wrist causes tingling. So these are the two maneuvers that suggest that there is some sort of carpal tunnel syndrome. Then causes: pregnancy due to edema, rheumatoid arthritis, hypothyroidism, and diabetes. Acromegaly, dialysis related amyloidosis may be associated with the repetitive use. Treatment: a longitudinal incision through the transverse carpal ligament, flexor retinaculum relieves the pressure of the nerve, and the ligament attaches to the hamate and pisiform on the ulnar side. So hamate and pisiform, so it's pisiform and hamate bone on the ulnar side, and trapezium and scaphoid tuberosity on the radial side. Okay, so if we cut it open, like make a transverse incision, longitudinal incision, that, so that will cause the relief of the pressure. Then we have musculoskeletal system. This is diabetes related amyloidosis. Amyloid deposits from the form from beta to microglobulin. So the diabetes related amyloidosis has the amyloid deposition in the form of beta to microglobulin. Complication of renal failure. Dialysis does not effectively, it's not diabetes, I'm sorry, it's dialysis. So dialysis related amyloidosis, amyloid deposits from the beta to microglobulin. Complication of renal failure. Dialysis does not effectively remove beta to microglobulin. Bones, joints, and tendons are the site of its deposition. Shoulder pain and carpal tunnel syndrome can be a complication. So here you can see that this is carpal tunnel, transverse carpal ligament, that is a carpal tunnel. So we do a longitudinal incision in that to relieve the pain or to relieve the symptoms. Hook of hemate pisiform carpal tunnel, ulna, blah blah blah. So here you can see that this is the carpal tunnel, a better picture of that. Over above the flexor retinaculum, the transverse carpal ligament is seen to be forming the roof of the carpal tunnel. Then inside the carpal tunnel, we have the following structures, but the main one that we are focusing right now is the median nerve. Then we have flexor digitorum superficialis tendons, these four. Then flexor digitorum profundus tendons, the four below that. The flexor pollicis longus tendon is also passing below that, and carpal tunnel. So basically, all the flexor are passing below it. The ulnar nerve and the ulnar artery, both of them are passing in a separate canal that is not the carpal tunnel. In the flexor retinaculum, there is a canal that is called the Guyon's canal through which the ulnar nerve and ulnar artery are passing. Then the flexor carpi radialis tendon is also passing through the canal. I guess there is some tendon or something. I don't know. Then we have thenar eminence is towards the side of your thumb, and hypothenar eminence is towards your pinky finger or the little finger. This one is hypothenar, and this one is thenar eminence over here. Then we have carpal tunnel with the contents. So let's move on to the what's that? The cubital tunnel, ulnar tunnel syndrome, caused by the ulnar nerve compression at elbow, cubital tunnel syndrome, or the Guyon's canal, that is ulnar tunnel syndrome. So Guyon's canal is also called as ulnar tunnel, and then there is something called as cubital tunnel. I have no idea what that is. Let's see that. The cubital tunnel. So the cubital tunnel is basically, this thing is called cubital tunnel. Cubital tunnel syndrome is a condition involves the pressure or stretching of the ulnar nerve, which can cause numbness and tingling in the ring and small fingers, pain in the forearm, and a weakness in the hand. Okay, so there is, you can just imagine it. There must be a tunnel or something, but imagine it that as the ulnar nerve is passing through the cubital fossa or across it, so it is compressed over there. Cubital tunnel syndrome. Yep. So this is cubital tunnel syndrome. The lateral, okay, so I guess it is compressed inside the lateral collateral ligament. Maybe there can be a thing that it is compressed in the lateral collateral ulnar collateral ligament, or the ulnar collateral ligament and the medial collateral ligament. I'm sorry. So the nerve can be compressed over there. What causes cubital tunnel syndrome? Cubital tunnel syndrome may happen when a person bends the elbow when pulling, reaching, or lifting the knees on the elbow, or a lot, or other injuries to the area, arthritis, bone spurs, previous fractures, blah blah blah. They can be the cause of it. Okay, so moving forward. So ulnar nerve can be compressed at the level of cubital fossa or at the level of Guyon's canal or ulnar tunnel, floor formed by the transverse carpal ligament. Okay, so the floor of the Guyon's canal, the roof of the carpal tunnel was being formed by the flexor retinaculum or the transverse carpal ligament. Now, the floor of the Guyon's canal is formed by the flexor retinaculum or transverse carpal ligament, because you can see that this is the Guyon's canal. If this is the Guyon's canal over here, so the floor is given by this retinaculum. Okay, then we have it like the roof is formed by the palmar fascia, the volar carpal ligament. Okay, palmar fascia is basically the ligament of the palmaris longus muscle. So it is, the palmar fascia is like that. I will take a picture of that. Classically seen in the cyclists due to the pressure from handlebars. So in the cyclist, due to the pressure on the handlebars, we can see the ulnar nerve compression. So let's see the palmar fascia, then we'll move forward. Palmar fascia. So palmar fascia looks something like that. So this central fascia is called the palmar fascia. Okay, so let's zoom it over here. This fascia, the structure that is present over here, this thing is called the palmar fascia, which is giving the, the palm of your hand, the rigidness which it has. So let's move on. Same presentation for each. So for both of them, we have same presentation. Okay. Then moving forward, it presents with the paresthesias of our medial 1.5 finger and the ulnar dorsum of hand. Okay, so medial 1.5 finger and ulnar side of the dorsum of hand as well. Claw hand, weakened grasp and pinch, exacerbation with the extensive flexion, especially the cell phone use, and night symptom caused by sleeping with arm in the flexion position. Okay, so this is the position, this is the thing I was talking about in the paresthesia, that the symptom or the the feeling that you have in your hand if you had your arm flexed for a very long time and then you extend it, so there is pin prick sensation in your hand all over, so that thing is called as paresthesia. Then we have musculoskeletal system. Okay, then we have Guyon's canal syndrome or ulnar trap syndrome. So here you can see this thing is called Guyon's canal. This tendinous canal is called as the Guyon's canal, and if it is entrapped over there, if it is causing the nerve entrapment over here, so that is called as ulnar canal syndrome, that is happening because of hamate injury or maybe pinched. So if there is hamate injury, so in that case there will be pinching of the ulnar nerve over there. Note, cubital tunnel covered by the Osborne's ligament, Guy's canal covered by the volar carpal ligament. So the Osborne's ligament, pardon me, the cubital tunnel covered by the Osborne's ligament, Guy's canal covered by the volar carpal ligament. Volar carpal ligament, okay. Cubital tunnel covered by cubital tunnel covered by Osborne's ligament. Okay, so let's see the cubital tunnel and Osborne's ligament. Osborne's ligament. Osborne ligament. So Osborne ligament is present over here. This thing is called as Osborne ligament that is present in the cubital canal, and cubital canal is a real canal present somewhere or in the near the elbow. So this thing is called as Osborne canal, and this Osborne canal can lead to entrapment of the ulnar nerve. Okay, I have a firm belief that this Osborne canal is some part of the ulnar collateral ligament. So Osborne ligament, and then we have other thing was the Guy's canal volar carpal ligament. So let's see that as well, and then we'll move on. Volar carpal ligament. Volar carpal ligament. So volar carpal ligament is this thing. I don't know, it's not mentioned over here. Volar carpal ligament. Just give me a second. Let's see the discussion. Volar carpal ligament, the palmar carpal ligament, also called as the volar carpal ligament, is a thickened portion of the antebrachial fascia on the anterior part of the wrist. The palmar carpal ligament is different structure than the flexor retinaculum of the band. Okay, I was wrong. Just give me a second. The volar carpal ligament is not palmar fascia. It is something else. And secondly, the volar carpal ligament is present over here. Okay, so volar carpal ligament. Okay, why are not depicting that? So you can see this in this picture, that this thing is volar carpal ligament, and the if you remember, so this is volar carpal ligament, and the carpal tunnel, the flexor retinaculum, that was present over here. Like, it is different from that, and it is also different from the palmaris fascia. It is not that. Pardon me for that. I previously have said the wrong thing. So palmar carpal ligament is present on the prior to your wrist, and that is giving the roof of the Guy's canal, and the Guy's canal can become or the ulnar nerve can become entrapped in the Guy's canal because of compression by the volar carpal ligament. So the cubital tunnel is covered by the Osborne's ligament, while the Guy's canal is covered by the volar ligament. Moving forward, we have the muscles of hand. So firstly, let's see the bones of hand. So the orange ones, these orange things, these are called distal phalanges. Then we have the intermediate phalanges, and then the proximal phalanges. So this one, they form a single unit that we call a phalanx, or your finger. Then we have metacarpals. Metacarpals is making most of the bulk of your palm. And then we have two layers of carpals that are proximal carpal layer and the distal carpal bone layer. Okay. Then we have thenar eminence towards your thumb and the hypothenar eminence towards your little finger. So thenar, remember, th is for thenar, th is for the thumb, and hypo means the most smallest finger of your hand is this little pinky finger. So hypothenar means something related to that. Intrinsic hand muscles. Thenar, median. These are apparens pollicis, abductor pollicis brevis, flexor pollicis brevis, superficial head, deep head by ulnar nerve. Okay, so these are the muscles of the thenar eminence which are being supplied by the median nerve. Okay, so most of them are being supplied by the median nerve. Yeah, apparens pollicis, abductor pollicis brevis, flexor pollicis brevis, and the superficial head, because the deep head is supplied by the ulnar nerve. Hypothenar is supplied by the ulnar nerve. Apparens digiti minimi, abductor digiti minimi, and flexor digiti minimi, these are being supplied by the ulnar nerve. Both groups perform the same function: oppose, abduct, and flex. So they off. Okay. What the point of this mnemonic? OAF, OAF, and OAF. Oh, that's a good mnemonic. So these are OAF muscles which perform OAF. So OAF means apparens pollicis, abductor pollicis brevis, and flexor pollicis brevis in the thenar eminence, and apparens digiti minimi, abductor digiti minimi, and flexor digiti minimi. So basically, just you have to flip flop this pollicis with the digiti minimi to make them hypothenar muscles. And remember the name of the movements, that is oppose, abduct, and flex. Oh, that's so cool. And the thenar eminence is being supplied by the median nerve, and the hypothenar eminence is being supplied by the ulnar nerve. Moving forward, we have dorsal interosseae. They are being supplied by the ulnar nerve, and they abduct the finger. So there must be a mnemonic of dab and pad. If there's not, so we write it over here. So it is like D, A, B, dab, and then there is a mnemonic called pad. So the dorsal interosseae pad. Yep. So dorsal interosseae are being supplied by the ulnar nerve, and they abduct the finger. Abduct means, you know, they cause the spread of your finger like a big palm. And then the palmar interosseae. The palmar interosseae are also supplied by the ulnar nerve, and they adduct the finger. So interosseae are being supplied by the ulnar nerve, and the dorsal one will cause abduction, dab, and the palmar ones, they will cause adduction, that is pad. Lumbricals first and second by the median nerve, and third and fourth by the ulnar nerve. So ulnar nerve is supplying most of the muscles of your hand, including the hypothenar eminence, including the interosseae, and third and fourth interosseae, third and fourth lumbricals as well. Well, the first two are being supplied by the median nerve. Okay, so flex is the lumbrical will flex the metacarpophalangeal joint, extends the proximal interphalangeal joint and the distal interphalangeal joint. L shape of the hand. So what is the L shape of the hand? L shape of the hand, this L shape. Okay, so oh, that's so cool. This L shape of the hand is given by lumbricals. So lumbricals will give the L shape of the hand by extending the proximal interphalangeal joint. Okay, the proximal interphalangeal joint is extended, and distal interphalangeal joint is also extended, and flexion of the metacarpal joint. So L shape of the hand is maintained or made by the lumbricals. Loss of lumbricals will lead to claw fingers. So if we lose the lumbricals, we'll get claw fingers. Okay, moving forward, these are palmar interosseae muscles over here, and then we have the dorsal interosseae muscle over there. Palmar one's interosseae muscle of the left hand palmar view, and the interosseae muscle of the left hand dorsal view. Extrinsic hand muscle. Now let's talk about that. These are called extrinsic hand muscles. There's the difference between intrinsic and extrinsic hand muscles. Intrinsic hand muscles are present inside the hand, right? They are originating inside the hand and also are inserting inside the hand, while the extrinsic hand muscles are coming out of the hand, that is from the forearm. Most of them are coming from the forearm. The origin is in the forearm, or maybe to some extent arm, and they will be inserting inside the hand. So that is why they are called as extrinsic hand muscles. So underside the forearm, okay, flexor digitorum profundus, median and ulnar portions. Okay, it is supplied by both the nerves, median and ulnar portion. Major flexors are supplied by the median and ulnar nerve, that is flexor carpi radialis and flexor carpi ulnaris. Okay, while the major extensors are all supplied by the radial nerve, that is extensor carpi radialis longus, extensor carpi radialis brevis, and extensor carpi ulnaris. Then we have distortion of the hand. At rest, a balance exists between the extrinsic flexors and the extensor of the hand, as well as intrinsic muscles of the hand, particularly the lumbrical muscles, flexion of the metacarpophalangeal joint, and extension of the distal interphalangeal and the proximal interphalangeal joints. Second and third lumbricals innervated by the median nerve, yes, and fourth and fifth lumbricals which are innervated by the ulnar nerve. So there is a balance between all of these things. If the balance is lost, we'll have a distortion of hand. So the first one is clawing. So claw is revealed when the patient is asked to open the hand and the affected fingers remain partly closed, or when trying to make a fist and the affected fingers remain open. Okay, seen best with the distal lesion of the median and the proximal ulnar nerve, that is called as ulnar paradox. Seen with the distal lesion of the median or proximal ulnar nerves. That is very important, that if the ulnar nerve is damaged proximally, that will cause ulnar claw hand. But if it is damaged distally or what? Seen best with the distal lesion. Okay, I have to check that. Give me a sec. So yes, there was a confusion and I cleared that. So here you can see that they are saying that the clawing is seen best with the distal lesion of the median, or just cut this proximal, or ulnar nerve. So in the FA 2022, it was like last version, FA 2021. So in the 2022 version, they're saying that the clawing is best seen with the distal lesion of the median or ulnar nerves, right? And the point of ulnar paradox is there, that the point of ulnar paradox is, let's Google that. Let's read it from Google and then I will explain that. So ulnar paradox, it refers to the different manifestation of the high ulnar nerve lesion at the elbow and the low ulnar nerve lesion at the wrist. In high lesion, the clawing is paradoxically more mild than in the low, and the reason is that if the ulnar nerve lesion occurs more proximally, closer to the elbow, the flexor digitorum profundus muscle is also denervated. As a result, the flexion of the interphalangeal joint is weakened, which reduces the claw-like appearance of the hand. So the claw-like appearance is because the claw-like means that the finger are more flexed, and finger are flexed because of flexor digitorum profundus. If the flexor digitorum profundus is also denervated, so the flexion movement, that is the characteristic of the claw hand, that is lost. So we don't find a very characteristic claw movement or the claw distortion of the hand if the ulnar nerve is being entrapped or damaged proximally, that is near the elbow. So that was the point. It was also mentioned here in this PDF that over here, just give me a second, clavicle, no, radius, and then we have it like ulnar nerve. Yep. So it was mentioned over here that the proximal lesion appears less severe. Proximal means close to the elbow. Proximal or elbow lesion, ulnar claw hand may not be seen. The ulnar digit paralyzed without clawing due to the loss of flexor digitorum profundus. So the confusion is settled down now, that the more the clawing is best seen with the distal lesion to the median or ulnar nerve, that is distal lesion to both median and ulnar nerve will show a characteristic clawing pattern, that is ulnar paradox. Remaining extrinsic muscles of the digit exaggerate the loss of lumbricals, that is fingers extend at metacarpophalangeal joint and flex at the distal interphalangeal and the proximal interphalangeal joint, that is seen in this picture. There is an extension, if you could see this. So there is an extension at this joint, but flexion at the distal and proximal interphalangeal joints. So this is the characteristic claw hand or the ulnar claw hand. Deficits are less pronounced proximal lesions, okay, in I guess both the proximal lesions. Deficit present during the voluntary flexion of the digits. Okay, so deficits are less pronounced in the proximal lesions and deficits are present during the voluntary flexion of the digits because both median and ulnar nerves are supplying the flexor compartment of the forearm as well, right? Remember, the extensor compartment is supplied by the radial nerve while the flexor compartment is supplied by the median and the ulnar nerve. Now, if they are damaged proximally, so proximal entrapment of any of these two nerves will cause the denervation of the flexor muscle as well. So the flexor muscle are gone, so the flexion, the clawing movement of the which is caused by the flexion will be less evident. So for both the nerves, the proximal lesion will show less clawing, and deficit during the voluntary flexion of the deficits will be seen if there is proximal lesion. Then presentation. What's that? These are 1, 2, 3, 4 kinds of claw hands. So the presentation. The context is extending fingers at the rest. Extending finger, context is extending finger at rest when we are trying to open the fist or we are trying to extend the finger or at rest, so we can find this hand. Location of lesion is distal ulnar nerve, right? And the skin will show, a sign will be ulnar claw hand. Now another ulnar nerve lesion, if it is proximally, so what happens that when we are making the fist, the proximal ulnar nerve damage will not allow us to make a fist completely, and that is an OK gesture, like an OK gesture. So here you can see that when we are talking about the distal ulnar nerve lesion, only the intrinsic muscles of hand are damaged, and that is why the effect which is shown by the other normal muscle is exaggerated and we are finding this claw hand like deformity, right? But if there is proximal muscle involvement, so the problem is now with the extrinsic as well as the intrinsic muscles. So what is happening here, that the extrinsic muscles of the hand, the extrinsic flexors of the hand are gone, so we cannot perform flexion anymore. Here we cannot perform the extension. Here we can't perform the flexion. Remember the difference. Then we'll talk about the median nerve. So median nerve, now this hand looks very kind of similar to this one, and this hand is similar to this one. The difference is in the cutaneous innervation or the loss of cutaneous sensory innervation. If the ulnar nerve is entrapped, so the claw hand or the claw hand will be present with the paresthesia or loss of sensation in this region. While if it is the median nerve that is involved, so there will be problem making the fist in the proximal median nerve. Okay, and there is also difference. Okay, and the sign will be Pope's blessing, right? Now this hand is shown when we are trying to make a fist with a proximal median nerve injury, and it is shown with the distal ulnar nerve injury. Okay, it's a new thing for me. Let's go check that. Yeah, it's right. Okay. So let's get along with this one. So this hand thing is seen with the distal ulnar and the proximal median nerve injury, and this hand is seen with the distal median and the proximal ulnar nerve injury. Okay. Then we have extending fingers at rest will cause this hand, and that is called median claw hand, and this one is Pope's blessing, and this OK gesture and ulnar claw. Okay. So make your own set of explanation for all of these because it is like very intricate anatomy and I have a very weak anatomy. So I was trying to explain this one. I was partly right and partly wrong as well. So just try to make sense out of these things. Okay, moving forward, atrophy of the thenar eminence, unopposable thumb or ape sign can be seen in the median nerve region, while the atrophy of hypothenar eminence can be seen with the ulnar nerve region. So that is also a differentiating point between both of them. Here you can see the median nerve is supplying the thenar eminence. So this is the thenar area. So if there is atrophy of the thenar muscles, we can see the monkey hand or the ape hand. But if there is hypothenar eminence atrophy, so that is basically due to the damage to the ulnar nerve. Moving forward, we are talking about the palm sensation is not affected by the carpal tunnel syndrome. The superficial palmar cutaneous branch of the median nerve passes superficial to the carpal tunnel, and we have seen that in the picture. So here you can see that the muscular cutaneous nerve is applying superiorly, and then the radial nerve is supplying this part. Basically, radial nerve supplies the posterior aspect of the upper limb. Then we have C6 dermatome over there. Then 3.5, uh, 3.5, the lateral 3.5 part of the hand on the anterior aspect is being supplied by this nerve, that is median nerve, and the tips of the finger as well. And the anterior and posterior, palmar and dorsal, both halves of the both middle 1.5 fingers are being supplied by the ulnar nerve, and this is the ulnar nerve and the dermatome and blah 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 blah. Okay, now let's talk about thoracic outlet syndrome. The group of disorder that occurs when the blood vessels or the nerves in the space between our clavicle and the first rib are compressed. So there are nerves which are present between the clavicle and the first rib. If they are compressed, like over here, between the clavicle and the first rib, this is the clavicle and this is the first rib. If there is a compression between them, that is called as the outlet syndrome, thoracic outlet syndrome, or TOS. Okay, so let's see what are the structures which are passing over here. These are the brachial plexus nerves. Then this is the subclavian artery, and then we have this vein as well. I guess this brachiocephalic vein or subclavian vein. So here you can see that this is posterior scalene muscle, middle and anterior scalene muscle. So the cords of the brachial plexus, not cords, the roots of the brachial plexus come out of the neck between the anterior and the middle scalene muscles. They are passing below the clavicle and above the first rib. These are brachial plexus, this is subclavian artery, subclavian vein, and clavicle and sternum over there, first rib. So clavicle and first rib, these are the 2 bones which we are concerned with right now in subclavius muscle is over here. So moving forward, compression of the following: lower trunk of the brachial plexus or the clump keys paralysis, symptoms worse with the elevation of arm, and upper extremity numbness, tingling, and weakness will be felt. That is seen in the Pancoast tumor or anything that is causing that obstruction. Okay, subclavian vein, upper extremity swelling will be there, and subclavian artery, exertional arm pain, weak distal pulses will be felt. The TOS or the thoracic outlet syndrome most commonly occurs within the scalene triangle. So where is scalene triangle? I guess this thing is called scalene triangle, like this, and over here. So in the scalene triangle, we find the most manifestation of TOS formed by the anterior and middle scalene muscles and the first rib. So first rib below and anterior scalene muscle on the anterior position, and the middle is forming the posterior boundary. So this triangle is called as the scalene triangle. The anterior scalene muscle originates from the C3 to C6 transverse processes and attaches to the scalene tubercle of the first rib. The middle scalene originates from C2 to C7 transverse processes and insert into the posterior first rib. Structure passing through this triangle are the brachial plexus trunks and the subclavian artery pass between the anterior and the middle scalenes. The subclavian vein runs anteromedial to the triangle. Causes of TOS: anomalous cervical rib, extra rib with a C7 and the first rib malunion, the scalene muscle hypertrophy or anomalies, scalene muscle injury, for example, repetitive overhead arm movements and trauma, and Pancoast tumor. So these are the causes of thoracic outlet syndrome. That is anomalous cervical rib, that is an accessory or supernumerary rib that is present in the neck. Then we have scalene muscle, so there's the extra C7 rib and first rib malunion. Okay, so if there is first rib malunion, that can also cause troubles. Then scalene muscular hypertrophy or anomalies. So if this muscle become hypertrophy, this will compress these structures which are present between them. Then scalene muscle injury, repetitive overhead movements, overhead arm movements or trauma, and then Pancoast tumor. These can cause TOS, thoracic outlet syndrome. So there is a Uworld point about thoracic outlet syndrome, that interscalene nerve block so anesthetize the brachial plexus as it passes through the scalene muscle triangle. It is used to provide the anesthesia for the shoulder and upper arm. Nearly all the patients develop transient ipsilateral diaphragmatic paralysis due to the involvement of the phrenic nerve roots as they pass through the interscalene sheath. Okay, so we are giving the interscalene nerve block, so that can also compress or maybe depress the phrenic nerve innervation, and that will cause the diaphragmatic paralysis in the patients. Thoracic outlet syndrome, this is the anterior scalene, then we have anterior scalene, the middle scalene, posterior scalene is none of our business, so we'll keep our focus to both of them. And then we have the brachial plexus, the cervical rib. Okay, there is a cervical rib over there. Okay, this thing is called cervical rib in the picture. This thing that is compressing the roots of the brachial plexus as well, as you can see. These are not roots, these are roots. Yeah, roots or maybe trunks. Then cervical rib and subclavian artery and clavicle over there. Here you can see the supernumerary ribs or the cervical ribs. These things are called cervical ribs. I guess this is also a picture of cervical rib, maybe something else. This one, and there is something like that over here. There is something I can't understand what that is. Then we'll talk about the lower limbs. So lower limbs, firstly we'll talk about the knee joint. The knee joint contains a lot of ligaments. Firstly we'll talk about the cruciate ligaments. We'll keep it till here, and then we'll continue from the knee joint in the next session. So until then, Allah Hafiz and Fi Amanillah.